I'd like to let you know that Aussie MedEd is sponsored by OPC Health, an Australian supplier of prosthetics, orthotics, clinic equipment, compression garments, rehabilitation devices for doctors, physiotherapists, orthotists, podiatrists and hand therapists. If you'd like to know what OPC Health offers, visit opchealth.com.au and view their range online. Medical statistics plays a fundamental role in shaping modern healthcare. It's the foundation of evidence-based medicine, allowing us to make informed decisions, whether it's selecting the best treatment, evaluating the efficacy of interventions, or even understanding the risks and benefits for our patients. In today's episode of Aussie MedEd, we're looking at the world of medical statistics, exploring how it influences clinical guidelines, helps us critically evaluate research papers, and informs everyday clinical practice. We'll cover the essential statistical concepts every healthcare professional should be familiar with when reviewing research, from types of data and statistical concepts to more complex topics like hypothesis testing, p-values, confidence intervals, and correlation versus causation. We'll also talk about other study design, the importance of sample size, and how to spot potential bias in research papers. Joining me today is Dr. Adam Badenoch, an anaesthetist who has a master's in biostatistics. He's going to help us break it all down for you. Whether you're new to research or looking to refresh your knowledge, this episode will give you tools to better understand and apply the evidence in your clinical practice. Welcome to Aussie MedEd. Good day and welcome to Aussie MedEd, the Australian medical education podcast, designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Diamond, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghana land. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Ghana people, and pay my respects to the elders both past, present and emerging. Well, it's my pleasure now to introduce Dr. Adam Badenoch, an anaesthetist trained in South Australia and who has specialised fellowships in difficult airway management, medical education and simulation, as well as hepatobiliary and liver transplant anaesthesia. In 2023, Adam earned a Master's of Biostatistics from the University of Adelaide, combining his clinical expertise with a deep interest in research, statistics, and anaesthesia specialties such as ENT, neuroanaesthesia, and liver transplant care. Thanks, Adam. Thanks very much for coming on Aussie MedEd. Statistics has always been a very difficult and confusing concept for myself, probably because it combines both mathematics and some unusual concepts. Can you please start off by explaining some basic key statistical concepts for everyone, basic principles that people should be aware of and what they should know if they're trying to analyse medical research?
Sure, Gavin. First of all, thanks for having me on. I, at times, find statistics a bit confusing and complicated too, so don't worry, I think, if that's how you feel. Lots of people are in the same boat, and it definitely does cover some relatively unintuitive concepts or logic at times. But I think you're right, covering some basics often helps. I think a few key concepts to understand are what sort of data are there and how do we categorise it? How can we describe different types of data? And some basic concepts related to hypothesis testing. So types of data can generally be classified into numerical or categorical, and the numerical data can be further categorised into discrete or continuous data, and categorical data is often further delineated into nominal or ordinal categories. A nominal categorical variable is simply one which has no logical order to it, and a good example might be hair colour, as opposed to an ordinal variable which is categorical in nature. It categorises things, but they have a natural order to them, such as small, medium and large. In terms of the numerical data, discrete data is data which essentially is like an integer. It doesn't take on a continuous range of values, but it falls into discrete numbers, whereas continuous data is essentially a numerical representation of something which can theoretically be described as an entirely continuous process that can take on any specific value. So if we think of continuous data, we often describe it in terms of its central tendency, which is where the largest amount of the data sits. and how the data is spread around that area of central tendency. So the most common ways to describe central tendency would be mean, median, or mode, the mode being the most common value, the median being the 50th centile value, and the mean having a number of different definitions, but the usual arithmetic mean is simply the sum of all of the values divided by the number of values. Distribution can be described as a range from the lowest to the highest value. You can describe subsets of that range, such as an interquartile range describes the middle 50% of the values. So it's less affected by occasional extreme outliers at either ends of the range. And a variance is definition of a term which describes how far each individual point is away from whichever measure of central tendency you use, usually the median.
Right, so when we're talking about numbers in general, we'd like to average things, and that's the mean, but I understand the mean's not as good. That's affected by outliers, and that's why the median's more useful. Is that correct?
Yeah, it depends on the distribution of your data. So the mean is a good value to use often because it takes information from every individual data point in the data set, and it uses that information in its calculation. So you're not throwing away any information, but because of the way it's calculated, it can be quite affected by a small number of particularly high or particularly low values that don't really represent the typical value of the data, if there is such a thing. The median takes the middle 50% of the values. So it is effectively discarding information from, the top tail and the bottom tail of the data set. And for that reason is, I guess, less desirable to use than the mean if those values at either end of the range are actually considered typical and representative of the true data set. But if they are unusually high or low outliers and we don't think that they genuinely represent the true population, then it's a good thing to discard that information and just use the middle 50%. The range takes that concept even further and simply uses two values from the data set. So you might have 1 million values in your data set, and to describe it simply using a range, all that does is it takes the lowest value and the highest value, and you usually put a little dash between them, and you say, the numbers range from this to this. And it doesn't tell you anything about what else is happening in the middle of the data set. So that can be obviously hugely influenced by outlying values and doesn't tell you anything about the middle of the range. But I guess it's a useful concept, particularly when combined with a median. So the median looks at the middle 50% of values and the range looks at the extreme ends. Then it can give you a nice little picture and summary when taken together of what the distribution of the data looks like. So it's horses for courses a little bit, I'd say.
And all these things are really used as a way of describing numbers in order to interpret results, as a way of assessing how well treatment can be useful for certain individuals or for a population in general.
I mean, statistics is it's a mathematical concept which is useful not just for medicine, but it's used in finance and engineering and agriculture and all walks of life, really. So anywhere where numbers can be used to represent phenomena that exist in the real world, statistics can be useful. So the applications are virtually endless. I guess one of the key concepts for statistics, and another one which often gets a little bit forgotten when people are interpreting statistics in medical literature, is that anytime we do a study or we analyse a data set, typically that is a sample which has been taken from a true population. So it may be, for example, that we've recruited 100 patients who have had knee operations from all of the patients that you've operated on over the last 12 months. Now, you might have operated on well more than 100 patients in 12 months. And what we're looking at in the study is a sample of all of the patients that you operate on. Or we might be trying to extrapolate our thinking to all of the patients who have knee operations, not just by you and not just in this year. So that concept that when we analyse a study, we're analysing a sample taken from a larger true population is a really important one. And often when we come back to interpreting some of the analysis parameters and testing hypotheses, that a lot of that framework is based around estimating what we think these values would truly be if we had collected data on every person that had a knee operation.
We've introduced that concept of hypotheses. Perhaps you can explain that in more detail if you could, please.
Sure. So hypothesis testing, I guess, is a way of using the statistical methods to refute a null hypothesis. And that framework of thinking is generally derived from the concept that unless we know that we're going to improve life or medicine somehow, particularly for our patients, we would usually defer to the status quo unless we know that what we're doing can make things better.
On the basis of, above all, do no harm. Exactly.
And also based on the fact that you can have random variation in data sets as well, and we don't want to infer too much into those. We want to only make changes which take a lot of effort sometimes if we know that there's a true effect there and it's not just some random variation in the data set. So typically in a study that does involve a hypothesis test, there will be a null hypothesis, which the simplest scenario would be a study that involves two groups and a single intervention. And the null hypothesis would be that there is no difference between the two groups, which means that the treatment doesn't have any effect. So if we conduct a hypothesis test, we're really looking at our data set from our single sample and trying to work out whether that data is consistent with the null hypothesis or not. And if it's not consistent with the null hypothesis by a small amount, we may say, well, there may be a small true effect here, but this might also be due to chance. Whereas if the data in our sample is very, very inconsistent with the null hypothesis, that's much more convincing for us to say, actually, we think we have enough evidence here collected that we can refute this null hypothesis with confidence. And in rejecting that null hypothesis, we obviously then come up with an alternative hypothesis, and that might be that the treatment improves the outcome that we're looking at, or maybe it makes it worse, and we can make an estimate as to by how much does it increase or decrease. So that's the general framework of thinking and ideas behind hypothesis testing.
And I believe that works then on working out the chance of that happening and using what we call p-value.
Absolutely right. Yeah, so a p-value is the chance of observing your data set if the null hypothesis is true. And obviously the more your data deviates from what you would expect under the null hypothesis, the chance of those results arising due to chance alone without your treatment having any true effect becomes smaller and smaller as the differences become more and more extreme. And the important thing to remember about p-values is that they have come under quite a lot of criticism in recent times, largely because that is the only information that they convey. They convey the probability that your results arose due to chance alone. And so the lower that chance is, the more confidence you can have in rejecting the null hypothesis. But it doesn't tell you anything about the magnitude of the change that you're actually observing.
I always thought that increasing the sample size increases the chance of having a positive p-value, and that might be one of the reasons it was criticised in that sense. I also realised too that the actual value of 0.05 was just decided arbitrarily by Fisher, an early statistician, who thought that 1 in 20 was a reasonable number to choose.
That's absolutely right. So the value that you choose as the threshold for what you consider a significant p-value versus one which you're going to ascribe due to chance alone is completely arbitrary. There's been a convention for a long time now to set that value at 5% or 0.05. But as medical literature becomes more and more common, that there are more and more studies conducted and papers published every day, year after year, we start to see a little bit of a phenomenon whereby there can be other issues at play, such as publication bias and a few other bits and pieces, which mean that this conventional thinking that 1 in 20 chance is something which is never going to happen unless there's a true effect. If you've got thousands of papers being published, every day, and they're all testing hypotheses, that's way more than 20 papers. You're going to get lots of them that are going to have statistically significant results due to chance alone. And so for that reason, there's probably a bit of a push to start using lower p-values to define significance, and or just encouraging readers to interpret p-values without necessarily feeling forced to ascribe a single arbitrary threshold to them as to whether they're significant or not. You can certainly look at it as a probability chance as to how likely this data set arose due to chance alone, and make up your own mind about whether you think there's a true effect there or not.
What about the opposite end of the spectrum? So what you're saying at the moment is that 0.05 might be a bit high. What about the people who talk about, things approaching significant?
Look, there are probably two sides to that. On one hand, I think to maintain integrity in the research process, you do need to be faithful to the traditional scientific method. And I think to claim that you have found a causal link between something, requires a whole lot of things to line up, one of which is to have observed a difference, a true difference due to your intervention. And the way to do that really is to define what you think is an important difference clinically before you start the study, and to also define exactly how you're going to analyse the outcome. And as part of that, I think you do need to define a threshold level of significance and stick to that in your analysis and in your write-up. Certainly that can be frustrating for authors, I think, who might in their data set observe probably the effect that they were looking for. The effect might be slightly smaller than they were expecting, or the variance in the data set slightly higher than they were expecting. And as a result, their p-value is not quite as small as the threshold value that they had picked prior to starting the experiment. So in those scenarios, I think as the author of the published paper, you just need to stick to your a priori decision-making framework. But that's not to say that as readers, we can't also consider the fact that p-values are simply probabilities that results arose due to chance. Yes, the arbitrary thresholds are important, but they can be interpreted in another framework, I guess, as the reader, if you're not the person who has set the level when you're registering a study, for example.
So what about my other thought too? The larger the study, the greater the power of the study, the more chance it reached significance. And so it almost seemed like if you just kept increasing the sample size, you'd end up, everything would be a 0.05 p-value. I'd like to let you know that Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's Specialist Referrals Directory, a specialist and allied health directory helping GPs find the right specialist.
Yeah, that's right. In the calculation of a p-value, usually the things that will influence it are the size of the effect, the variation that exists in the data set, and what the sample size is. So for any given combination of effect size and variance in a data set, the larger your data set, the smaller your p-value is going to be. And so as things like electronic medical records and data linkage and data sharing become more and more common, the possibility of mega data sets to emerge becomes more and more realistic and more common. And certainly that's a phenomenon worth bearing in mind too. So for any time that a p-value is presented and is very small, it means that there probably is an effect there, but the p-value may be small for any one of those three reasons. So low variance in the data set, a large magnitude of effect, or a very large sample size. So if it's a large magnitude of effect, then obviously that's clinically very important to us as clinicians. The other two are more statistical phenomena, which are not so important for how effective the treatment is. So it is important to look at the sample size when considering a p-value.
So if you see a positive p-value, but you actually see the actual overall result saying a very small effect, you might be thinking, well, okay, that's useful to know, but it's not going to really change my clinical practice as much as a huge variance with a positive p-value and a small sample size where you go, that's really important.
Exactly.
What about this idea of confidence intervals that you also see talked about as well? I'm a little bit confused on that because it seems to have a range and it has a number in the middle. Can you explain that to me? And does that have anything to do with what we're talking about with p-values as well?
Sure. So confidence intervals are a range of plausible values within which the true population value will lie with a particular degree of confidence. Typically, they're presented as 95% confidence intervals. So it's a range of values which will include the true population value with 95% certainty. So in many senses, they're analogous to p-values, but they have the added advantage of providing a range of values, not just a probability of whether something arose due to chance or not. So the range of values that's provided by the confidence interval can give you an idea of the magnitude of effect. Often they can be calculated around an estimated value. So you might estimate, the average difference in blood pressure between two groups. So the average difference in blood pressure has a single particular value, and that's the value that you'll see in the middle of the confidence interval range. And either side of that, you have the edges of the confidence interval range. So that's the range of plausible values that the difference in blood pressure could take.
So in that scenario, if you then gave a medication that adjusted the blood pressure of the group of patients, they would then have a range and a confidence interval of 95%. And then do you compare the two confidence intervals that way, and how do you do it?
Not ideally like that. So you could calculate a blood pressure value in the first group and a confidence interval around that. And you could calculate a blood pressure in the second group and a confidence interval around that. What would be preferable to do if you knew that the aim of your study was to compare the difference in blood pressure or how it changes when you administer your treatment? You can make the outcome of your trial deliberately the difference in blood pressure. And so that's blood pressure 1 minus blood pressure 2, and that then becomes a single value. You can then calculate a confidence interval around that single difference value, and that's much more useful and a more valid way of telling what the difference is between two groups than simply comparing the overlap of confidence intervals between two separately created confidence intervals.
We might come back to that example in a second when we start talking about the different tests and things we use, and talk about whether it's a parametric test and what test you'd use in that example. If we move on a bit further though, what are the common pitfalls in interpreting statistical data in medical studies, and how can they be avoided?
I would say that the most common pitfall is probably to assume that a study is well conducted and that the conclusions are valid. I find it's much better to assume the opposite and ask the authors to prove you wrong. If I can't do that, I just remain dubious. Okay,
almost like a null hypothesis on the study you're reading.
Exactly.
So what are the key characteristics of a well-designed and robust study that you need to look for?
So there are a number of factors, and really there's a huge long list of of things to look for, because good research is really just a process of doing lots of little things right. And if you do all of those little things right, then you'll have done good research. If you do none of those little things, then it's bad research. And there's a huge amount that sits in the middle there somewhere, where they've done some things right or many things right and some things not so well. But I guess some of the important concepts are to understand concepts like the study design is probably the single most important factor. So whilst it's possible to have a well-conducted case series or a well-conducted observational study, if we assume that studies have all been conducted with a similar level of rigour, then a randomised control trial that is blinded is a much better design than an observational study of any sort. And an observational study that makes some attempts to adjust for confounding is better than a case series, and a case series is better than a case report. So that level of evidence that people are probably familiar with in terms of an evidence-based pyramid still holds true. Probably the caveat to that is the fact that publication bias is a real phenomenon, and that can certainly influence meta-analyses findings. Often the meta-analyses and systematic reviews sit up the top of that pyramid, but sometimes if a meta-analysis shows a difference between two groups or that a treatment is effective, it's probably actually better to go and conduct a single, really well-designed, robust, large, pragmatic trial to confirm those results to ensure that it's not due to publication bias. If you've got a systematic review or a meta-analysis which demonstrates no difference between two groups, then we can be pretty confident that that hasn't arisen due to publication bias, and you can probably take that result as being a true one.
I was going to quickly just ask, just for the listener, what a systematic review and a meta-analysis is. Can you just explain to them what that involves?
Yeah, so a systematic review is simply a systematic search through the literature. Meta-analysis is a process which is used to pull results from multiple studies, and it comes up with an average effect. So often meta-analyses and systematic reviews are pulled together. You would need to conduct a systematic review before being able to conduct a meta-analysis. So that the idea of a meta-analysis is it's a way of generating a large amount of data to answer a question without necessarily needing to do that within a single new trial. It's using existing results in the medical literature to come up with what you think is a true result. It's particularly helpful if you have multiple small trials, particularly if they have some difference in their results.
And a publication bias would be where lots of studies have been pulled, but all the individual studies aren't of great quality, and therefore they influence the results.
Yeah, publication bias is typically this phenomenon whereby studies which show a difference between groups or treatment effectiveness are more likely to be published than those that don't. And so when people conduct their systematic review, generally you can only find studies that have been published. So there might be a whole range of studies that people have conducted which represent the true effect of your treatment or intervention, which have never made it to print and therefore never make it into a systematic review and meta-analysis.
Brilliant. Well, I'm learning all the time. So what other types of biases do we need to be aware of into trying to design a robust and ideal study?
Essentially, anything you can think of that can go wrong in a study can be a potential source of bias. Depends greatly on the study design and what you're doing. You might be conducting a survey. There might be ways that you're asking the questions which are a little bit leading. That can introduce bias. If you're measuring an outcome, it might be that if the person who's measuring the outcome isn't doing it in a particularly objective way, and if they know which group participant has been assigned to, that we have all sorts of inherent biases within us as humans that can happen whether we mean them to or not. There are other phenomena as well in trial conduct whereby patients might be excluded from the trials for particular reasons, and that might bias the results. Or it may be that if we're looking at how much a blood pressure pill drops our blood pressure by, if the pill which drops the blood pressure the most also kills patients, then the fact that patients drop out of our data set because they die is going to sort of dilute the observed treatment effect from the pill which drops blood pressure the most. So there's really no end to the potential sources of bias. They can be sort of typically categorised into some of the more common forms, but it can be anything really. It's anything which generates a systematic deviation from the truth.
Yeah, but in that pill discussion, if you had a red pill versus a blue pill, the blue pill might be more calming and get a slightly better drop in blood pressure because of the placebo effect as well. And that can lead to a treatment bias as well. Is that correct?
Yes, absolutely.
Is there any other particular things you'd like to do in a study apart from excluding bias and make sure it's been assessed appropriately and conducted appropriately? Is there anything else that can make a better study overall?
Yeah, so some of the other more important points are probably to register your study prospectively, publicly announcing what it is you're going to do, who are you going to study, what parameters are you going to collect, what is actually your primary outcome of interest, and how are you going to analyse it. If you can describe all of those things before you start your study, that gives you much more faith that there's a valid result and conclusion. The alternative to doing that is to not publicly disclose any of those things and simply publish your results and describe your conclusions after the study's conduct. The problem with doing that is this phenomenon of p-value hunting, which is a symptom of the publication bias that we referred to earlier. So authors know that their studies are more likely to be published if there's a difference between their groups. And often scientists, clinician researchers will conduct studies because they think that there is an effect there to be observed. And so if people are then left to their own devices, some of those inherent human biases can come out and people can sort of, change the outcome that they were initially intending to look at because one of the other outcomes they collected in their study now seems a much more interesting result. There's a difference between the two groups and it's now seems, quite clinically important. So maybe we'll report this one instead, or they'll slightly change the definition of how they define their primary outcome and report the newly defined version because that provides a more statistically significant and interesting result. So registering studies, protocols and statistical analysis plans prospectively helps to guard against those things.
And obviously for the listener, there's just things that can creep into studies and we need to watch out for.
Yeah, I mean, people do study this from time to time. They'll take random samples from even quite respectable journals and examine the incidence with which some of these things happen. And whilst it's not to say that this happens all the time and everyone does it, it certainly has a significant prevalence in the medical literature across all disciplines.
And what are the red flags that we need to look for in that scenario? Is it just the things you've already talked about? Are there anything particular that comes to mind that you see?
I mean, by and large, it's the opposite of all of the things we've just talked about that are the markers of good research. And any time you don't see those, potential markers of bad research. Another thing that can help sometimes in a study to set your mind at ease that a finding is robust and true is a sensitivity analysis. Because sometimes, despite our best intentions, there are actually multiple valid ways of defining an outcome or analysing a particular variable, and those different definitions and analysis methods can each have their own assumptions and drawbacks. Not that they're necessarily wrong to do it that way, but there are just some inherent assumptions that are made as part of the analysis process. So sensitivity analyses are designed to ask the question, what if we didn't make those assumptions? Or what if we use the alternative but also valid definition of the primary outcome? What if we analysed it in a different way, which is also considered appropriate, in our field? So going through that process and then verifying if we didn't make these assumptions and we did it this alternative way, do we end up with the same study conclusion or does it change our study conclusion? So if you do a range of sensitivity analyses and you get a different answer each time, that's quite unsettling in terms of, being able to have confidence in the result. Whereas if there's a range of sensitivity analyses that are done and they all support the same study conclusion, then you can have a lot more confidence that these little assumptions that are made each step along the way in the analysis and the definition of outcomes and perhaps the choice of the primary outcome as well, not making or breaking the study, I guess.
A question that's come to mind while we're speaking, are there any tools to help you analyse the research you're reading? Are there any guides or particular checkboxes you need to look at?
Yeah, there are. There are some really useful guides, checkboxes and help kits. Probably the best one to know about, which is the most widely applicable across all study designs and all research, are the consort tools and checklists. So Consort was a group that was formed designed to promote high quality research, and they have produced a range of guidelines and checklists which are really good if you're thinking of designing a study to use, but also as a reader as well. Anytime you pick up a new study and read it, if you're running a journal club or anything like that, they can be a fantastic resource to use. And they've got a different checklist for different scenarios. So there's a guide and a checklist for randomized control trials. There's one for meta-analyses. There's one for observational studies, and they're very useful.
So what sort of are the common tests we need to know or should be aware of?
I think the most common tests being used at the moment would be a student's t-test for continuous data and a chi-squared test or Fisher's exact test for categorical data. Those two tests are relatively easy to calculate and are very robust in a range of different scenarios. So they've become commonly used tests for good reason, and they can be applied to a large range of scenarios. So that they are good ones to know about. In terms of how many other tests there are a huge gamut of different tests out there, and whether or not to consult a statistician, there are some scenarios where I think if you feel confident to analyse a data set yourself, then that can be a great thing. And there are other times when, if you feel not so confident, that involving a statistician is a really good thing to do. And there's a range of complexities in data sets and analyses. And so where you sit as an individual and where the study data set and analysis sits on that spectrum is always going to be a different beast for different projects. I guess the one thing I've learned in my statistical studies over the years is how easy it is to get it wrong sometimes. So I've certainly learned to have a very low threshold for involving a statistician. Even being an accredited statistician myself now, I have a very low threshold for involving someone else. Not necessarily for them to do the whole analysis. In some cases where it's outside of my scope, I'll ask someone to do the whole thing for me. And in other scenarios, I might just ask for some supervision of what I'm doing. So I think any of those scenarios are okay. It's whatever you feel comfortable with. And even for a given individual, that will vary from project to project because different projects involve different levels of complexity. But I'd always err on the side of involving a statistician if you're not sure. And I would always err on the side of doing this work and putting this thinking in and involving the statistician if you're going to earlier rather than later in the project. Ideally in the design phase, the initial design phase of any study is where that involvement should come.
Healthcare professionals, how can they integrate these sort of assessments of studies and better evidence-based medicine into their clinical practice effectively? What are your thoughts on this?
That's a tricky one. So changing clinical practice is difficult and definitely not my area of expertise. I think understanding the evidence is the first step, and that's certainly where I am more comfortable. From there, I think, there are many other organisational and interpersonal elements that start to become increasingly important. And I guess, how do you make that transition? I guess starting to talk to your colleagues about this new evidence that you've read is probably the first good step. You'll get a little bit of feedback from them. And if you both agree, hey, this is a promising new revelation, maybe we should look at changing our practice, at least then you've got a friend alongside you. So that's probably as far as I would take it in terms of, my level of expertise. After that, there are lots of other people out there, lots of my colleagues who are much better versed in the ideas of quality improvement programs and organisational change. The role of managers comes into that. It starts to become, managerial domain as well. So depending on what the change is that you're trying to implement can be quite complicated and difficult, and whether or not there's evidence to support efficacy in terms of patient outcomes or cost effectiveness in terms of healthcare dollar savings is it's almost one small part of a much more complex piece of machinery to actually make that change in clinical practice, I'd say. I'm also aware that there's a science behind this change in clinical practice as well, which is not really my area of expertise.
Well, what we've really summarised is that statistics are important to analysing results, but unless you do a properly conducted study, assessing what biases there might be, outlining what you're planning to assess along the way, and using appropriate statistics to analyse that, then you can't really be confident that the results you're showing are definitely what is actually happening in real life. You've also got to assess studies that you're reading in a similar fashion and use tools such as that from you've mentioned, like the consort, to assess them. And also being aware that when you do assess a result that could be useful in clinical practice, to involve a team to help critically assessing it. Would that be a good summary of what we've been discussing today?
Yeah, I think that's a fantastic summary. You're well done.
I've always liked to finish off about the use of artificial intelligence. What about the role of artificial intelligence in helping analyse data? Or is that going to have a greater risk of introducing biases along the way?
Oh, look, I think you've hit the nail on the head. It has huge potential, but there are also the potential for major biases and problems. I think artificial intelligence covers a range of different concepts. The one which is probably most relevant to statistics is probably machine learning. Machine learning is a way of analysing data based on some automated pre-specified rules, but usually it is a multi-layered process, or a process which feeds back on itself numerous times. But each layer, or each time it conducts this process, it's usually doing some sort of relatively simple or straightforward analysis technique, which is not new. It's something that already exists in the world. For example, something like a logistic regression model. If you have a binary outcome, a machine learning model might use something like a random forest program, and that can use a series of layered logistic regression models to decide a final binary outcome model. And it does that without necessarily disclosing a lot of the information. I think maybe one of the things we could have talked about earlier that now becomes relevant to assessing AI stuff is it's always good to see the diagnostics of any of the analysis plans that have been done in studies. So ideally, if people can present their study data set in a de-identified manner, present the code that they use to analyse it, and some techniques such as regression models can often be tested to see how well the model actually fits your observed data. So those model diagnostics can be really good to present as well. So there's some things that can be good to look for in good research, and the absence of those things can sometimes be a flag for bad research. With AI, it just takes that to the next level because it's doing so much computational work. It requires a lot of code, and there's a lot of output from the code because it's running multiple models again and again and again in this iterative process. But really the only way to be sure that they haven't done something silly is to look at all of that code and all of that output. And so we don't necessarily expect that everyone will be able to understand that code and that output, but some people can. And I think the one thing that we would ask is that those things are published each and every time someone uses machine learning as part of an analysis method for a study, simply to publish the code, ideally the data set, and the output, so that it can be verified.
Basically, without knowing all the intricacies of what is actually computing, you really can't be sure that the numbers are coming out with the correct.
No, that's right. There are some scenarios where it can be really useful too. Like I think in something like image recognition, pattern recognition aspect of it, through an iterative process can be extremely useful. But you contrast that against something that has a numerical outcome. For example, if we come back to our blood pressure scenario, usually in a blood pressure study, the outcome is a number which can be calculated based on a relatively simple formula. So you'll see some people occasionally applying something like a machine learning model to calculate a blood pressure study outcome. And that's a huge waste of computational power and using an iterative process, which starts with a sort of a random guess as to what the number might be and gradually narrows it down based on your observed data set, when you could actually just calculate what that value should be through a relatively simple formula. So sometimes it gets a little bit misused as well. It's become a bit of a sexy term that people like to apply to whatever it is they're doing, irrespective of whether it's actually the most elegant or accurate way of deriving the answer.
Well, finishing off with that blood pressure model, would you use a chi-square test or student test to analyse the differences in blood pressure after treatment, or what would you tend to use in that scenario?
Yeah, so blood pressure is a numerical outcome, which theoretically could take on any number of values, not just integers. So it's a good example of a continuous variable, and we know that it's relatively normally distributed amongst most populations. So we can use a student's t-test to analyse it, or a linear regression model are two good ways that should give you the same answer, essentially.
Brilliant. Well, look, Adam, thank you very much for coming on Aussie Med Ed, enlightening us on statistics and the use in medicine. So thank you very much.
No worries, Gavin. Yeah, thanks for having me on. It's been great to be a part of your show.
That's brilliant. Thank you once again. I'd like to remind you that all the information presented today is just one opinion and that there are numerous ways of treating all medical conditions. It's just general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your GP or seek assistance from health organisations such as Lifeline in Australia. Thanks again for listening to the podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe. I'd like to let you know that Aussie Med Ed is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.